Hello guys, welcome back to Clinically Clear. So today we'll be covering another type of conjunctivitis, that is allergic conjunctivitis. Let's take it slow and keep it concise. So first the classification. So we have simple allergic conjunctivitis where you just have an allergy. It can be a seasonal allergy, it can be a perennial allergy throughout the year or specifically in some seasons. Then very important VKC, vernal keratoconjunctivitis. My bad, I've written vernal keratoconjunctivitis. Vernal keratoconjunctivitis, VKC, also known as spring catarrh. Very important. Then atopic keratoconjunctivitis, AKC, and giant papillary conjunctivitis. And there's one more, flectanular conjunctivitis. So these are the common types of allergic conjunctivitis. What's most important is VKC, vernal keratoconjunctivitis. So let's start with VKC. See, vernal keratoconjunctivitis, few important things you need to remember is bilateral. Of course, an allergy, it will be bilateral in most cases. Recurrent, intermittent, it will keep coming, symptoms come, symptoms go. Seasonal allergy, it is a very important thing. It is a seasonal. VKC is seasonal. Spring catarrh. See, think about it. Spring, something involving seasons. Self-limiting. It's not like it's there throughout the day. It's there, the symptoms are there throughout the day. It comes and goes. It stops by itself and then it again recurs. So it is an allergic inflammation of conjunctiva that is bilateral, recurrent, self-limiting, and seasonal. So let's look at the etiopathogenesis. So very important is this thing. Patient has to have some predisposition to some allergy, some atopy. Like patient has some other allergic conditions like asthma and eczema. Patient has family history of allergy. These are all some predisposing risk factors. Then other risk factors, I remember it through this sentence of there are 5 to 15-year-old Indian boys in summer holidays or in summer. So in this line you have all the risk factors, 5 to 15 years old, so at a very young age. Indian boys, so what do you think? Something to do with tropical climate, warm countries. Okay. Boys, sex, more common in males. And summer, this is much more common in summer. Actually, the name spring catarrh is a misnomer because actually the most symptoms appear during summer, during warm weather. Hence, it is also known as warm weather conjunctivitis. So, predisposition to allergy, and then you have risk factors like young age, male sex, warm countries, warm weather, and male sex. That is about risk factors. And what is this vernal keratoconjunctivitis or spring catarrh? It is basically a type 1 IgE-mediated hypersensitivity reaction to exogenous seasonal allergens, like example is pollen grains. So exogenous allergens which are seasonal in nature like pollen grain, you have a type 1 IgE mediated hypersensitivity reaction, and the reason is these risk factors and the predisposition to allergy. So like any hypersensitivity reaction, you'll have a lot of like any type 1 hypersensitivity reaction mediated by IgE, you'll have a lot of eosinophils, you'll have mast cell infiltration, WBC infiltration, histiocytes infiltration. All this leads to what? It infiltrates and makes the conjunctival layers more cellular. Conjunctival epithelium will have a lot of eosinophils, mast cells, WBCs, histiocytes. Then the adenoid layer will have a lot of these cells and cellular infiltration. Then even the fibrous layer will show proliferation, etc. And in the vessels, conjunctival vessels also, because of the inflammatory mediators, because of the WBCs and all that, the permeability increases and there is vasodilation. So there is conjunctival vessel, increased permeability and vasodilation. These are some of the pathological changes. These are the reasons why we have papillae. I'll come to the papillae, but this is the reason why you have papillae. Okay. Now let's look at the symptoms. Symptoms, think about it as allergy. So your patient continuously feels like rubbing, itching, burning sensation, irritation, burning, itching, irritation. So patient keeps rubbing their eye. And especially when they're exposed to warm, humid weather. That is why warm weather conjunctivitis, especially when exposed to warm, humid weather. Then you have other signs of allergy. Other signs of allergy like lacrimation, watering of the eye, lacrimation, watering of the eye. Then ropey white discharge. This ropey white discharge is when, for example, I have I start getting discharge, and then start rubbing my eyes because of the irritation and burning, and then I try to pull my finger away. That sticky with discharge, it forms like a rope. It comes like a rope. That is ropey white discharge. So these are some other allergic signs, allergic symptoms, and then coming to the signs. And remember, all bilateral. Very, very important. Vernal keratoconjunctivitis is bilateral. Most allergic conjunctivitis is bilateral, except one which I'll come to later. So, depending on the type of VKC, the signs differ. So, first let's look at the first type, that is palpebral vernal keratoconjunctivitis, and it is the most common. You have three important signs. Papillae is the first sign. I told you, because of all the cellular infiltration, vascularity, vasodilation. What happens? There are certain elevations, as you can see here, flat topped elevations, like flat topped elevations all over the upper palpebral conjunctiva. Very, 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 very important. VKC mostly involves only the upper palpebral conjunctiva. So you have upper palpebral conjunctiva, papillae, and these papillae, they give cobblestone appearance or pavement appearance. It looks like there's a bunch of cobblestones on the road, right? So you just have stone, 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 stone. So cobblestone appearance or pavement appearance. So number one, papillae in the upper palpebral conjunctiva giving rise to cobblestone appearance or pavement appearance. Second, let's say the papillae starts growing in size because of severity of disease. If it becomes more than 1 mm in diameter, then it is known as giant papillae. Second sign. And third sign, as I told, the stringy ropey white discharge, that is known as Maxwell-Lyon sign. So the stringy ropey white discharge is known as Maxwell-Lyon sign. So you have the stringy white ropey discharge known as Maxwell-Lyon sign. You have giant papillae, and then you have the cobblestone appearance or pavement appearance because of papillae in the upper palpebral conjunctiva. So these are the signs of palpebral VKC. Next, coming to bulbar limbal VKC. In bulbar limbal VKC, you have more involvement of bulbar conjunctiva and the limbal conjunctiva. So here the first sign is you have a triangular area of congestion, redness in the bulbar conjunctiva. You just have to remember it. I couldn't find any picture. Then you have something known as Horner-Tranta spots. Very, very important. So what is this Horner-Tranta spots in bulbar limbal VKC? Basically, because of accumulation of eosinophils, you have some raised white dots. As you can see here in this picture, you have some raised white dots in the limbus. In the limbus, bulbar limbal VKC, near the limbus, you have collection of eosinophils. So these raised white dots in the limbus is known as Horner-Tranta spots. Very, very important. Then if you have symptoms of both palpebral VKC as well as bulbar limbal VKC, then it is known as allergic, then it is known as mixed VKC. Okay. And remember something, most cases, whenever there is conjunctiva involvement, there will be corneal involvement as well. That's why we call it as VKC, vernal keratoconjunctivitis, because of involvement of both conjunctiva as well as cornea. Now think about it. In VKC, what did I tell? There is more involvement of upper palpebral conjunctiva, right? So because of that, there is more involvement of always the upper part of the cornea as well. So the corneal lesions, the corneal signs are known as vernal keratopathy. Vernal keratoconjunctivitis. So just the corneal signs, if I want to say, vernal keratopathy. So first it starts as superficial epithelial punctate keratitis, where I just have in the cornea some dot like tiny lesions on the corneal epithelium. Now let's say they get a bit bigger. Then you have certain corneal macro erosions. Now there are two things can happen to these corneal macro erosions. Either that discharge, that exudate can deposit over it to form plaques, vernal corneal plaques. For example, see here you can see it's in the upper part of the cornea. This is the cornea in the upper part of the cornea. So vernal corneal plaques, or these macro erosions can enlarge, and when they enlarge, they'll form ulcers, and the ulcer is known as shield ulcer. Very, very commonly asked question. Shield ulcer. You have a transverse ulcer in the upper part of the conjunctiva. Here it's not exactly in the upper part of the cornea, sorry, not conjunctiva, cornea, upper part of the cornea, but most of the times it is in the upper part of the cornea. You have a transverse ulcer known as shield ulcer. And then the last corneal sign is pseudogerontoxin. Now what is pseudogerontoxin? It is also seen in a condition in old age known as arcusinitis, but mainly what happens, there is lipid deposition in the limbus. This is the cornea, this is the limbal area, right? So here you can see As you can see here, there is lipid deposition in the limbus that forms a bow-like outline. So this is known as Cupid's bow. So bow-like outline known as Cupid's bow due to lipid deposition in the limbus. This is known as pseudogerontoxon. So 5 vernal superficial epithelial punctate keratitis became macroerosions. Either that became a plaque or it became a shield ulcer, and then you have pseudogerontoxon. Next, coming to differential diagnosis. See, differential diagnosis, VKC also involves upper palpebral conjunctiva, where you have papillae. Acute inflammatory trachoma, where you have a lot of papillae. There also there will be more involvement of upper palpebral conjunctiva. But you can differentiate between the two based on the type of discharge. This ropey white discharge is only in VKC. Here you will have little bit of mucopurulent discharge in trachoma. This is one differential diagnosis, but the most confusing one is this: VKC versus AKC, atopic keratoconjunctivitis. See, VKC, as I told, 5 to 15-year-old boys, young boys. AKC, atopic keratoconjunctivitis, equal sex predilection as well as more common in old age. VKC, where did I tell? We'll see the papillae, the upper palpebral conjunctiva, cobblestone appearance. In AKC, atopic keratoconjunctivitis, there is more involvement of the lower palpebral conjunctiva. That is why what happens when the patient keeps rubbing the lower part of the eyelids like this, like this, like this, like this, two things happen. There is an extra crease in the lower eyelid. See, if you look at your eyes, there is just one crease there. But when you start getting these extra creases, then they are known as Denny Morgan's folds. Denny Morgan's lines or Denny Morgan's folds. Excuse me. Then you have Hertog's sign. Now, what is Hertog's sign? Hertog's sign is when, because of the rubbing, continuous rubbing again and again, AKC, atopic keratoconjunctivitis, in the lateral part, the eyebrow gets lost. That is Hertog's sign. So, AKC, more involvement of the lower palpebral conjunctiva, loss of lateral part of the eyebrow, Hertog's sign, as well as an extra lower lid crease known as Denny Morgan's line. Next difference is VKC is more of seasonal, I told, exogenous seasonal allergens like pollen. AKC is perennial. VKC is self-limiting. AKC, atopic keratoconjunctivitis, it is chronic, it does not limit, it can lead to serious vision loss. AKC is actually a very dangerous condition. So what is the differences between VKC and AKC? Vernal keratoconjunctivitis, self-limiting, seasonal, then more of upper palpebral conjunctiva, young males, whereas atopic keratoconjunctivitis, old, no particular sex, not self-limiting, chronic, can cause severe damage, perennial in nature, more involvement of lower palpebral conjunctiva, therefore you see stuff like Denny Morgan's fold, Hertog's sign, etc. Next, coming to the treatment of vernal keratoconjunctivitis. Now, the treatment of vernal keratoconjunctivitis is topical antiallergics. In topical antiallergics, you have three things. You have topical steroids like prednisolone, but these topical steroids, they are anti-allergic, but only for acute exacerbation you should use it. You should not use it on a regular basis because then it will lead to steroid-induced glaucoma. Very, very important. You can also give topical mast cell stabilizers like sodium chromoglycate and ketotifen. They stabilize the mast cell, they inhibit the degranulation of these mast cells, therefore they prevent the type 1 IgE-mediated hypersensitivity reaction. But the topical anti-allergic, that is drug of choice, is olopatadine and alcaftidine. Now, olopatadine and alcaftidine, these are dual agents. They act as both antihistamine as well as mast cell stabilizer. So, because they have anti-allergic action through antihistamine as well as mast cell stabilizer prophylactic action, these are the drug of choice for VKC, vernal keratoconjunctivitis. But let's say patient has severe VKC and steroids also are not enough to reduce that allergy. Then you can give some topical immunosuppressants like cyclosporine. You can give systemic drugs like oral anti-allergics, oral antihistamine, oral glucocorticoids, steroids. Okay, this is about severe cases. Then supportive therapy for symptom relief. You can give dark goggles for photophobia, cold compresses for soothing effect. If there is any vernal corneal plaques, to break that mucus plaque down, you can give mucolytics like acetylcysteine. Then you can also give artificial tears like 1% carboxymethyl cellulose for that irritation, itching sensation. But for some things like the corneal plaque as well as the shield ulcer, you can't really do much about it because you have to do surgical intervention. Medical intervention is not going to work. So that is about the treatment. Main thing you need to remember here is dual action agents, topical steroids, topical mast cell stabilizers, topical agents. Then if severe, either you go to topical immunosuppressants, or that also doesn't work, go to systemic therapy. Then supportive for symptomatic relief, you have acetylcysteine, you have artificial tears, dark goggles, cold compresses, etc. And for shield ulcer and plaque and all, usually you have to go for surgical intervention. Then coming to next one, giant papillary conjunctivitis, short topic. Basically, as you can see, you have huge papillae. Why? Because it is more than 1 mm. If it is more than 1 mm, then it's giant papillae. This is a type 4 hypersensitivity reaction to mechanical antigens or physical antigens. So basically, some mechanical antigens like keratoprostheses, that is art corneal transplantation or any fake cornea, then any contact lens, any sutures, then what happens? Type 4 reaction to this leads to the formation of these giant papillae. Well, how do you treat it? Just remove this physical antigen. Eventually, the type 4 hypersensitivity reaction will reduce and you can limit it. Next, coming to flectanular conjunctivitis. See, flectanular conjunctivitis is a type of allergic conjunctivitis where you'll see nodules or flectins. These nodules, also known as flectins, are seen in the limbal area. Here, it is a type 4 hypersensitivity reaction to the endogenous microbial antigen. Type 4 hypersensitivity reaction to endogenous microbial antigen. So, endogenous microbial antigen, hence also known as microbial allergic conjunctivitis. Why microbial allergic conjunctivitis? Because you have an allergic reaction to the microbial antigens. Which microbial antigen? Staphylococcus antigen and tuberculous antigen. So these are some examples. Some other bacteria or some other organisms or microbes also you can have, but most commonly staphylococcal and tubercular antigen. Here also risk factors. How will you remember? I've just put a simple sentence: thin, poor, young Indian girls. Okay. Now thin because of malnourishment, poor because of poor hygiene, overcrowding, etc. Indian tropical countries, warm weather, young age, and more common in female sex. That's why girls. Then coming to pathogenesis. Pathogenesis, 4 stages it passes through. First, you have a nodular stage. Then you have a nodular stage where it is present near the limbus. So it is present near the limbus, and you have a type 4 hypersensitivity reaction to the microbial antigen, where the center of the limbus you have polymorphonuclear leukocytes, and surrounding that you have lymphocytes, and around that you have vascular congestion. See, here you can see lot of vessels being congested, vascular congestion. So this is a flectin. So center you have infiltration. It is a type 4 hypersensitivity reaction, right? So you have infiltration of WBCs, leukocytes. So in the center you have PMNL leukocytes, polymorphonuclear leukocytes. Then surrounding that you have lymphocytes. Surrounding that you have vascular congestion in these flectins or nodules near the limbus. So first, this infiltration leads to the formation of these nodules or flectin. Then what happens? Stage of ulceration. These nodules or flectin, they start to go for necrosis and they ulcerate. Once they form an ulcer, stage of granulation. Granulation tissue begins to deposit at the floor of the ulcer. And whenever there is granulation tissue, it is always indicative of healing. So stage of healing. So first is near the limbus, there is a formation of a flectin or a nodule because of a type 4 hypersensitivity reaction, where you have polymorphonuclear leukocytes, lymphocytes, and vascular congestion. Then stage of flectin nodule can go into necrosis and ulceration. Then stage of granulation tissue deposits, followed by stage of healing. Coming to the symptoms, symptoms are basically, one thing here you need to remember is, here it is unilateral. Flectanular conjunctivitis, symptoms are more unilateral. All other types of allergic conjunctivitis, most of the times it is bilateral, but here it is unilateral. And what will you have? You will have allergic symptoms like itching sensation, burning sensation, irritation, watering, etc. Basic. Then signs depend on the type of the flectanular conjunctivitis. The most typical type, the most common type is the simple flectanular conjunctivitis, where you will have the usual flectin in the limbus. What is it? Pinkish white nodules surrounded by vascular congestion, vascular hyperemia. Pinkish white nodules surrounded by vascular hyperemia. That is simple flectanular conjunctivitis. Next, coming to necrotizing flectanular conjunctivitis. Once this flectin goes into necrosis ulceration, necrotizing flectanular conjunctivitis. Let's say the patient has many flectins, multiple around the limbus, near the limbus, 1, 2, 3, 4, 5. So it start forming a ring, and this ring of flectins, if it ulcerates, it lead to a ring ulcer. So what are the three types? Simple flectinular conjunctivitis, typical flectin, pinkish white nodular tissue surrounded by vascular hyperemia, and then you have in the limbus, then if it goes into necrosis and ulceration, necrotizing flectinular conjunctivitis. If you have multiple forming a ring, then ring ulcer, or lead to ring ulcer. And another thing you should remember is flectinular conjunctivitis will always be accompanied with corneal involvement. So flectinular keratoconjunctivitis. So this flectinular keratitis part can be of two types. It can be infiltrative type, where just you have diffuse infiltration of these WBCs and all, polymorphonucleocytes, lymphocytes and all into the cornea. And infiltration is followed by vascularization. That is infiltrative type of flectinular keratitis. Ulcerative type, basically you can have three different types of ulcers. Scrofulous ulcer. Scrofulous ulcer is a very shallow ulcer. If you have a small flectin that just breaks down, lead into a shallow ulcer. That is scrofulous ulcer. Miliary ulcer. See, miliary flectinular conjunctivitis, what did I tell? Multiple flectins near the limbus. So if all these go into corneal ulceration, then multiple ulcers, miliary ulcer. Then fascicular ulcer is when the ulcer is accompanied by a parallel leash of blood vessels. So whenever you have a parallel leash of blood vessels next to the uh, ulcer, then it is known as fascicular ulcer. So scrofulous ulcer, small flectin breaks down, scrofulous ulcer, and fascicular ulcer. Next to the ulcer, you have a parallel leash of blood vessels, as you can see in this image. And this thing, what miliary ulcer, you have multiple ulcers forming a ring around the cornea. Treatment, topical treatment, the drug of choice is steroid antibiotic. So topical steroid, not steroid antibiotic. Topical steroid is the drug of choice. You can also give antibiotics for any secondary infection. You can give atropine for corneal involvement, and then you can give atropine. Any corneal involvement, you'll give atropine for symptomatic relief. That is one thing. Antibiotic to prevent secondary infection, but the drug of choice is topical steroid. Just remember that. Apologies for the stammering. I just got confused for a bit. The drug of choice is topical steroid. Just remember that. Then specific treatment. You have to eliminate the foci of infection. Why? Because all these conditions, as I told, it is microbial allergic conjunctivitis. It is a type 4 hypersensitivity reaction to endogenous microbial antigens. So you have to eliminate the infection. You have to give anti-tubercular treatment, and you have to give some general therapy like nutritional therapy to the child. Because why? As I told, thin girls, thin young girls, thin young Indian girls. So thin under nutrition is a very important risk factor. So that is the treatment. Just remember that the drug of choice is topical steroid. So that is about flectinular. I covered most of the types of allergic conjunctivitis. That's it. Thank you for watching.